Couple of nerds in here. Okay, that's a big nerd right there. I love it. Gal after my own heart. I love that. Okay, that was awesome. It was awesome. Just y'all are such a great audience. You know, I'm here all semester. It's amazing. Okay. Yeah, that's right. That's right. Keep on coming back. Keep on coming back. It's a public institution. People are welcome to come in and sit in the empty chairs. Okay. We started a little late. I got distracted talking about soccer, so sorry for the late start. Yeah. Who earns a living driving people away? Earns a living driving people away? A Greyhound bus driver, a taxi driver, an Uber driver? All right. Too many options, it's not as funny anymore, huh? Okay. What did the tree say to the wind? What did the tree say to the wind? What's that? You blow me away? Leave me alone. Leave me alone. What kind of nut doesn't have a shell? What kind of nut doesn't have a shell? Try again. A donut doesn't have a shell. Clearly. Okay, so a couple of clarifying questions. These historic Greek terminologies of telencephalon, diencephalon. My goal on the exam is to not test you on Greek language. I'm just simply trying to give you some of the roots, the root words of where these structures originate from. So if you're in the literature in the future, as you move on in your studies, you actually have some historic knowledge of, yeah, there was some cephalana-like sounding term that I don't really remember what it was, but you can look back at your notes. On the exam, we'll ask about the cerebrum or the parietal lobe or the frontal lobe. I'll use the terminology that you're more likely to see in what you're seeing in lab. Okay, in lab, you're really not going to be talking about the telencephalon. You'll be talking about the cerebrum, the cerebral hemispheres, right? The left and the right side. One point of clarification as I was kind of looking at the lecture and thinking about today and Monday's lecture, one clarifying point that we will cover, but it'll be not until, it may not be, oh, it might be today. When we have information that comes up, sensory information from the periphery, and it comes up through the spinal cord into the central nervous system, and then it moves to the brain, the information actually crosses over as it comes up. It actually, the term is called decussates, and it crosses over at the level of the medulla, which is in the brainstem. So it's like in the neck. And then when information comes out, it actually crosses over or decussates at the medulla and goes to the opposite side. So for example, I'm using examples like, and you'll see this on the exam, and this is what made me think about it. I've already started writing the exam questions. If a patient wrestles with a stroke in the left premotor cortex, they may have loss of function on which side of the body? The right side, because of this crossing over. Okay? Sensory information, right? If they have a cerebral infarct or a stroke, or they have a traumatic brain injury in the parietal lobe, and it's on the sensory side or portion of the parietal lobe, and it's on the right hemisphere, it's sensory information coming from where? Somewhere on the left side, because it crosses over as it comes up, okay? So let's finish out this theme of different structures of the forebrain. Forebrain made up of the telencephalon and the diencephalon. The telencephalon is the cerebrum, and I already mentioned to you, on the exam I'll use the terminology cerebrum. Depending if I'm feeling cheeky, I might put in parentheses telencephalon, but you'll see the word cerebrum, okay? Maybe just to kind of reinforce the terminology. But I'm not going to ask you to memorize these old Greek terms. Now, the diencephalon, the thalamus, the hypothalamus, the pituitary, and the pineal gland, that's what we're going to cover next. So this thalamus is a relay center. The thalamus serves as a monster relay center for the brain. And this relay center for the brain is really important because it really brings information all the way up from the body on its way to the cerebral cortex. The medulla is down at the level of the brainstem, so we'll talk about it later. But this information that is coming into the thalamus actually sends it to all the different spaces, integration centers, that give you sort of this multiple piece of information about input, right? We talked about how you have a smell during Thanksgiving time, an aroma that fills the house, and all of a sudden you have all these memories, and you have emotions, and everything kind of comes back, stuff from your childhood. So the thalamus is sending that information to a couple of different areas. It surrounds the third ventricle. So it kind of gives you an orientation of where you find it within the body. It does connect to the hypothalamus, and hypothalamic control is actually really important. It's not a huge structure in the brain. Hypo meaning under. So you can see this picture. This is the thalamus. Right below the thalamus is the hypo, or underneath the thalamus structure. Now, the hypothalamus has centers that regulate every single one of these things on this list. That would be good to know. It would be good to put this to memory. Thirst centers. It controls whether or not you decide it's time to take a drink of water, or you think that you've had plenty of water. It helps regulate that water balance, which obviously goes hand in hand with thirst. Pleasure centers are located here in the hypothalamus. There could be certain foods, certain chemical groupings that actually trigger pleasure centers. I mean, when I say the word pleasure, all of you have different ideas in your head, but there are different things as mammals that give us pleasure. In simple, yummy food, there is a pleasure associated with that. Okay, and there's a satisfaction, satiety that's associated with that. Now, some other types of centers like rage, sexual desire, hunger, your appetite is controlled by the hypothalamus. It helps to impact sleep patterns. It doesn't necessarily solely regulate sleep patterns. We'll talk about the pineal gland here in a second. But it also regulates temperature, whether you feel hot or whether you feel cold. And last but not least, it kind of goes with rage, but aggression, centers for aggression. So there are patients that will have cerebral infarcts, and portions of the hypothalamus, stroke, portions of the hypothalamus may be impacted, and they may change their behavior. They may become very aggressive or belligerent. And before, the family's like, I don't know what's wrong with Grandpa. He was always very quiet and meek. Well, this is what's going on, is some of these behaviors actually will change. Hypothalamic control. Okay, the pituitary and the pineal glands. So the pituitary gland, it contains hormones that help regulate how we grow and our metabolic processes. It regulates blood pressure, pregnancy, sexual organ development, as well as maturation and cycling that takes place based upon sexual hormone fluctuations. The pituitary gland, there's two portions of it. There's an anterior and a posterior. And you're going to learn more about it in the endocrine section in 202. But aberrations of the pituitary gland could lead to what we call pituitary giganticism, or somebody that's really, really tall, really, really big. They make more adrenocorticotropic hormone. In turn, it actually produces or stimulates the release of more growth hormone. And growth hormone has impacts on bone, muscle, and individuals get really large. Like, anybody heard of the professional wrestler Andre the Giant? So he was kind of one of the most popularized pituitary giganticism patients. And then the other can happen, where you have too little release out of the pituitary gland, and individuals are small in stature or behind on their growth chart. So if you're going to go into pediatric medicine and you're interacting with families where maybe the kids are not growing as quickly as the parents want, right? And you're going to start chasing down different, questions of, is everything okay with my kid? And so you'll look at hormones that are circulating in the body. You may or may not scan the pituitary gland to see if it's operating correctly, because it controls growth. Now, it's not the only thing that it controls. You can see the list here of sexual organ development, blood pressure, pregnancy. But a lot of endocrine hormonal regulation happens from the pituitary gland. It sits in this location in the skull known as the hypophyseal fossa. It's kind of like a fossa is like a bowl, like a little indention. Now, the pineal gland is really an interesting gland. Sitting down here, so kind of inferior and anterior to where the hypothalamus sits. And the pineal gland regulates our circadian rhythms, our light-dark cycle. It releases a substance known as melatonin, not to be confused with melanin. Melanin comes from what? Skin melanocytes, right? Gives pigmentation to the skin, has a UV protection barrier to the skin, right? Melanin is the brown color in skin. As you tan, it gets darker, right? The melanocytes make more of it. Melatonin, some individuals take over the counter if you work the graveyard shift, if you're traveling into different time zones, you go to Europe, you wake up, now you're awake when everybody else is asleep. So when it is dark out, the amount of melanin actually goes up in the body circulation, and it's what makes you sleepy. So a lot of patients will take this, a lot of individuals take melatonin as more of a safe alternative sleep aid. Non-habit forming, they say, right? But everything is habit forming to some extent. But it's not a narcotic. It's not a pharmaceutical. It is a natural clearing substance, and it really does help make you sleepy and fall asleep. It doesn't necessarily keep you asleep. All right, let's look at structures of the hindbrain and the midbrain as we finish out this lecture, and then we'll move quickly into the next PowerPoint series. So the hindbrain meaning the back. We're looking at the cerebellum, the medulla oblongata that I've been talking about, the pons. So these structures, we were pons, medulla oblongata, and the cerebellum. Cerebellum looks like a piece of cauliflower. So hindbrain. The pons and the cerebellum are part of this metencephalon, and the medulla oblongata is an outcropping of what we refer to as the myencephalon. So the hindbrain is made up of the metencephalon and the myencephalon, pons, cerebellum, and the medulla oblongata. So the cerebellum up first. Pretty easy to identify. It's in the posterior aspect. It's also helpful to know that, you can orient the brain very quickly. If you see the cerebellum, and this is a cutaway, so it looks more like this, which actually has these gyri-like structures, which are referred to as folia. But it does the same purpose as the gyri, where it increases the surface area, bless you, of the architecture of the cerebellum. What's located in the cerebellum are functions for muscle coordination, helping with posture. So communication between the cerebellum and the vestibular apparatus in the internal ear, or the inner ear, are what give you posture, balance, equilibrium, sitting upright, being able to walk straight. When people are inebriated, it's not just a balance issue within the inner ear, right? There's an alteration of brain function, and cerebellar processes are impacted. And so there's dizziness, the room's spinning, they can't walk straight, and they don't really sit up straight either, right? Patients that, might come into the ED on a Friday or Saturday evening, for those of you that work those shifts, right? Their posture is not what it is in this classroom right now. They're slumped over, right? They don't sit upright. So the cerebellum is absolutely impacted. This structure also controls the passage of time, or helps you to conceptualize the passage of time, whether it's 1 minute or 1 hour or 1 year. The structures, these folia, are the ridges, like what we talked about, synonymous to the gyri. Similar to the left and the right hemispheres, you have this vermis that connects the cerebellar hemispheres on the left and the right side. And the architecture on a cutaway slice, and you'll see this when you dissect the sheep brain, I think in a couple weeks here. You're going to do a sheep brain dissection. And if you do a mid-sagittal section right down the middle and you open it up, you should be able to see really nicely this tree of life, or what we refer to as the arbor vitae. And the arbor vitae are white matter axons. So they're myelinated white matter axons that make up kind of the tree portion. And then everything outside of that is gray matter, non-myelinated. Kind of a similar organization. All right, as we continue through the hindbrain, we look at the medulla oblongata. The medulla oblongata, this forms a portion now of the brainstem. So remind me of the axes that I described to you, like left, right, front to back, top to bottom. Explain to me how that organization works. Any volunteers? Just start with one and tell me, how's it set up? Left, right. What are some of the differences between left hemispheric control versus right hemispheric control? We're talking about the cerebrum. What are some things that are on the left side, the left cerebrum? Speech centers. We had two specific ones we looked at, right? We looked at Broca's and Wernicke's. What else? Logic, reasoning. How about on the right hemisphere? Creativity, language, music, religion. Okay, how about posterior to anterior? How is it organized? Posterior to anterior. Sensory towards the back, and then motor towards the front, or output towards the front. Very well done. Okay, rostral to caudal, or top to bottom, superior to inferior, which is relevant in this one. We're at the brainstem. Are we top or are we bottom? We're bottom, right? The cerebrum's up top, the brainstem's here in the neck, so you're going down. And what did we say as you transition from top to bottom, the type of processing happens in the brain? Where's more complex function happen? Top. Where's more basic, or what we call autonomic function happen? Bottom. So the brainstem is at the bottom of the brain, And so here you're going to have a lot of autonomic functions like cardiac and respiratory rate, stuff that you don't even think about. You know, it's not some mathematical algorithm you're trying to compute to determine how fast to beat your heart or even how many breaths to take. Does that make sense? So here at the brainstem, autonomic centers, we have reflexes. Reflexes are things that you don't think about. We're going to talk about some reflexes here today. Reflexes for coughing, sneezing, all right? It happens a lot in this classroom. Gagging, swallowing, vomiting, salivation, and sweating. These are all reflex centers that are located at the medulla oblongata. Now, the other thing that's interesting about the medulla oblongata that's kind of, it's a little bit more morbid, but it's interesting to know. We'll put it in the context of a brain injury or a brain stem injury. But in the old world, when we did capital punishment, death by hanging, which we don't do that anymore, right? We're still capital punishment in certain parts of the world, including our country, but not by hanging. So snapping the brainstem or fracturing the brainstem at this location, the axis of the vertebrae would pierce the medulla oblongata and would stop heart rate and breathing almost instantaneously. So a lot of people think like the death by hanging was, I mean, you're like suffocating somebody while they're hanging. No, it's actually you're fracturing the medulla oblongata and you terminate heart rate and breathing instantaneously. Okay? Also happens to be the location from a military standpoint where snipers and police are trained to take out a target, and they actually aim for the brainstem to take out these cardiac centers. Okay. Similarly, and one of your colleagues and I were talking this morning, and we were kind of talking about some of these clinical examples of, hey, you know, what if you ask on the exam, like, hey, a patient had a stroke of the precentral gyrus, what's going to be the clinical manifestation? So, well, that's a perfectly great test question. And we're assuming when we say that the manifestation of that is that the patient actually survived. Because unfortunately, with a lot of strokes, not everybody survives a stroke. We're talking about the patients that actually survive. A stroke of the medulla oblongata, the survival rate is not high. Are you with me? For probably obvious reasons. Okay, last but not least, in this particular section, and then we'll move to the midbrain as we wrap it up, is the pons. So the pons is a really large structure that, you know, is just superior to this medulla oblongata, part of the brainstem. So you've got some relay centers from the cerebrum to the cerebellum. So from the cerebrum up top to the cerebellum towards the back, it's passing through the pons. And it has a lot of connections that take place for functions like monitoring sleep, hearing, equilibrium, taste, eye movements, facial expressions, breathing, swallowing. And breathing and swallowing, now these are some of those autonomic functions too, right? As well as bladder control. So again, you can kind of see on the list things that aren't under always conscious thought process. Facial expressions are, eye movement sometimes is, but there are certain facial expressions and eye movements that are more reflexes, right? Somebody tells you something and, you know, or somebody walks in and you're like, and they're like, oh, wow. And you're like, it's so good to see you, right? Your reflex was like, but it's so good to see you. Like, you can't control that reflex sometimes. So the pons is kind of that border between higher thinking, controlled, voluntary versus involuntary autonomic control. Look at where it's located. It's kind of right in that border, which should make some sense. Okay, now we're going to move right into the mid-center. We're going to talk about a couple of simple structures here as we wrap up this portion of the lecture. And then we'll move quickly into the next slide deck. The midbrain, mesencephalon. We're in the middle portion. And there's two structures here known as the corpora quadrigemina that I want you to understand. Corpora quadrigemina. So there's four structures. But you have a superior colliculi and you have an inferior colliculi. And these midbrain structures, known as the inferior and superior colliculi, are referred to as the hills. So you can see them in this preparation. So this is the thalamus right here. And below the thalamus, we've got the two pairs of the superior colliculus and the two pairs of the inferior colliculus. And collectively, because there's four of them, that's known as the corpora quadrigemina. So what do they do? Well, the superior colliculi are what help you with the tracking of movement of objects. So like a friend is skating across campus or riding a bike across campus, and you're tracking and saying, oh, I see, that's Joe. And so you're able to track because of these structures in the brain. Now, similarly, the auditory reflex of tracking or determining where sounds are originating and understanding if they're coming closer to you or further away, that's the inferior colliculi. So that's these two structures. And this allows for tracking of an auditory reflex. So for example, sirens. An ambulance siren or an emergency vehicle siren, you obviously notice it, but then if you turn down your radio or you kind of pause for when you take out your AirPod when you're cruising through campus, you can kind of determine, is it getting closer to you or is it getting further away? And that's not something that you really actually have to teach anybody, if you've thought about it. Like, you could figure that out when you were a kid. There wasn't like a class to determine like, hey, when the sound waves actually get closer and closer together, it sounds like this, and that means it's getting closer to you. You could ask a little kid, is that ambulance getting closer to us? And they'll be like, nope, it's going further away. How do you know? I can hear it, right? This is intrinsic into our brain. It must be really important when we hear sounds to be able to identify, is that coming closer to me or is that getting further away? There wasn't some physics formula that we actually had to learn as children to figure that part out, right? It's kind of fascinating. So that's hardwired in our brain. The ability to track like this as visible objects are moving by, and the ability to listen to a sound and know, is that danger getting closer to me or is that danger getting further away? Lots of other things labeled on the slide. Those are the things that I want to focus on. Superior and inferior colliculi, and those two examples. Okay, our last slide as we wrap up this section is this reticular formation. Now, the reticular formation is a little interesting. It's actually difficult to label it on a slide. The reticular formation is sort of indicated by these blue arrows that emanate out from basically all regions of the brain. It kind of looks like it's coming out of the thalamus, but the reticular formation is a loose network of gray matter, so it's unmyelinated. It spreads vertically through the brain stem and connects much of the cerebrum to the brain stem. It helps to coordinate somatic control, motor control. It helps to regulate cardiovascular centers, pain, sleep, consciousness, and habits that we form on a regular basis. So this is sort of like the integration center that takes place, the reticular formation. Between the thalamus and the reticular formation and other like tracts that are association tracts or the corpus callosum that connects the left and the right side, this is how the brain kind of maintains all of this information in a harmonious fashion, because we really have a lot of input overload, if you think about it. A lot of input overload throughout our daily life. Questions over what we've covered so far? Okay. We're going to move into a little bit of review, trying to get you ready for next Wednesday. So I'd like you to answer this question that's being posed on the precentral gyrus. Precentral gyrus is responsible for which of the following? Raise your hand if you've got it. E, directing motor movements, right? It's the motor cortex. It's on the frontal lobe. Very good. Okay. A 67-year-old woman experiences a stroke to her right temporal lobe. Her right temporal lobe. Which of the following will most likely result from this permanent damage? Now in the exam, I don't have F and G, so it's, a little overkill on the number of answers. But read them through. Raise your hand if you think you got it. What's gustation? Taste. Okay. You got it back here? Okay, let's hear it. Loss of gustation on the left side, yeah. And loss of hearing on the left. Yeah. So G, two of these, right? Agreed. That was that crossing over thing that I had to explain to you before I showed this one. Okay. Brain lesion. Patient never feels full, but eats so much now that she's nearly 600 pounds. The lesion is most likely where? Raise your hand if you got it. Hypothalamus, why? Hunger. Hunger centers. Okay. You should know this list. Be able to label these structures on a picture. I mean, hypothetically, if there was a picture on a screen with arrows pointed to certain things, I'm making stuff up here, but okay? All of these we've covered. There shouldn't be one here that you don't understand. Here's a perfect example of what that could look like. Jeez, Keller. Wow. Here are where those answers would be found. Make sense? Broca's area, frontal lobe, Wernicke's, more posterior, sensory. What are some of the functions of each of these? Okay, let's go inside to the interior. A list of structures that you should be able to recognize. Label. Good? Okay. So we're still in the central nervous system, but we're going to transition further south, or we're going more inferior. We're going down into the spinal cord. And we're going to not get through this entire lecture today. We'll finish it up on Monday. But we'll probably get a decent way through. And Monday will be a lighter day, which is good because the exam's on Wednesday. Monday's material is game on for Wednesday's exam. But we probably won't have an hour and 15 minutes of new material. Okay? So we're still in the central nervous system. We need to chat a little bit about what the spinal cord does. A lot of spinal cord purpose is passing information from the periphery to the central nervous system, from the central nervous system out to the periphery. In addition to that, we have a lot of reflexes. If you've got this central nervous system that's about like this, and something's happening in your big toe, you could get something to the central nervous system, like in the lumbar region, and back to the big toe about the same speed at which it's going to go to the brain. And then it's got to go all the way back to the big toe. So having local reflexes at the spinal cord is a great way to organize local responses that can be pre-programmed. And that's really what a reflex is. Now you touch something hot, you're like, whoa. And then you're like, ow, that hurts. Like, so you move typically before you actually even feel the pain or actually even have like the concept of, was that on? Like you do this and it comes away because the signal comes to the spinal cord and back as a reflex for you to move. At the same time, the signal is still going up to the brain to process the sensory input to say, that's hot, move your hand. Oh, I already did. That hurts. Cry. Okay? Does that make sense? So it's just kind of the programming is fascinating because that's the role of the spinal cord, is to kind of serve as this sort of local relay center so that we can interact with our environment much quicker. We don't have to wait for it to get all the way to our brain. Even though we send it up myelinated tracks to get it to the brain faster, it still has a long distance to go because we're sort of big organisms. Okay, so that's kind of the purpose. So we've got local, what we call central pattern generators that are made up of reflexes that happen at the local level. And we're going to talk about a few of these as we talk through the spinal cord. So in a prep, we're taking a slice transverse this way. And now you're looking at it down. And you kind of see this butterfly structure. So that's kind of a classic picture of the spinal cord. And just to orient you where you are, you can see this vertebral body, right? Here's the vertebral body. This is the anterior or the front portion. Here's the posterior portion. You've got these, nice bony structures, but they have a lot of foramina or holes or spaces where nerves can come in and out of. And really, really convenient is right down the center, completely encased in bone, much like the brain, is where the spinal cord actually travels or lives or is hosted. And then when we look at the actual spinal cord, we can kind of appreciate sort of this architecture, and we're gonna sort of dissect this a little bit more on the ventral root horns and the dorsal root horns. And we call them ventral, even though we refer to this as anterior, and we call them dorsal because a lot of the neuroscience research associated with central nervous system is done on organisms that are on 4 legs, right? So vertebrates that are, not walking upright. We're not doing a lot of primate research and neuroscience. We're doing invertebrate and vertebrate research on sort of lower order species. And so the dorsal root horn is posterior and the ventral root horn is anterior, but dorsal and ventral usually refer to like 4-legged animals, right? So that's the reason for that nomenclature. A lot of times students are like, why isn't it called the anterior root horn? Just because of where the research originated. Okay? It's not technically wrong to call it the anterior root horn, but the ventral root horn is really what the literature says. Okay? So, what do you notice about these meningeal layers from where we just came from? What do you notice about them? Same exact as the brain. Same order. The cerebral spinal fluid that we manufacture in the ventricles at the level of the choroid plexus, that you remember when we walked through that flow chart of how it moves? That'd be a really good flow chart to remember. How does that, where's it made? Where does it go? Where does it empty? Does it surprise you for me to remind you, because we talked about it when we talked about cerebral spinal fluid, that it actually, all that fluid circulates right through the spinal cord. It circulates through the subarachnoid space, which is between the arachnoid mater and the pia mater. And that's where it perfuses in the spinal cord. The spinal cord doesn't have ventricles like the brain, but it has a subarachnoid space. Okay, now we have these major regions of the spinal cord, the major regions. We have the neck region, which we refer to as cervical. We have the chest region, which we refer to as thoracic. We have the lumbar, which we refer to, or sorry, the lower back, which we refer to as lumbar. And then we have the sacrum, or the tail, which is referred to as sacral spinal nerves. And all of these levels have nerves that leave the central nervous system and extend out into the periphery. And once they leave the spinal cord, they become peripheral nerves, right? Magically. But that's where like the label moves from central to peripheral. Just like what we saw with cranial nerves. Remember how I told you cranial nerves are technically not part of the central nervous system. But there, if you take the brain prep of the sheep brain in the next couple of weeks in lab and you look underneath it, inferior, you're going to identify some cranial nerves that you can see. And those are extensions out of the central nervous system, leaving, going out into the periphery. Same concept is happening here with the spinal cord. Similar kind of organization. So we're now on a sagittal view of the entire spine. And if you look from where this eye picture is, so you're looking from the posterior aspect, we have this natural curvature of the spine that takes place. And we're not talking about the spinal cord, we're talking about the vertebral body that encompasses the spinal cord. So we're kind of shifting in this part of the lecture to be focusing on the bony structure, which we refer to as the spine, but it houses the spinal cord, which is part of the central nervous system. So the spine and spinal injuries are really dangerous, right? Because they're sort of subject to the elements or our daily lives and can directly impact the integrity of the spinal cord because the spine houses the spinal cord. So we see in the neck region, we see what's called cervical lordosis. So that's a concave to the posterior aspect. And then it's convex thoracic kyphosis. Kyphosis is this curvature. Lordosis is this curvature. The lumbar is a lordortic angle because it mimics the cervical region. And then back in the sacrum, it's a kyphotic angle. So 2 lordortic angles, 2 kyphotic angles. So what's interesting developmentally is from an embryologic standpoint, right, we develop in utero with a primary curve as an embryo, like this. So our back is shaped like a C. Our spine is shaped like as it's developing. And then when infants start lifting their head, what does the bone do based upon the stresses that it's placed under? When they start lifting their head, what does it do? It remodels and reforms based upon Wolff's Law that we've already learned, right? So when the infant lifts their head and starts looking around, that's when the cervical lordortic angle begins to develop in early childhood, early infancy. And the kyphotic angle, which is the original angle from embryonic development, stays. Then where do you think this lordortic angle takes place in development? When we start standing and pulling ourselves up, and then we start taking our first steps, right? Because we're putting our hip underneath our head, arms, and trunk. And now that bony structure has completely new forces, and it takes a completely new curvature. Okay, so evidence that, like, I'm not just making this stuff up, right? That the Wolff's Law that we learned about like a unit ago completely goes into the shape of our spines today. And now we're going to start looking at, as we get older, how things change based upon different attributes. Or when we have different injuries, how things change based upon different attributes. Okay, so we're going to go through them. very, very methodically, very organized. Cervical, then we'll do thoracic, and then we'll do lumbar. Kind of potentially finish up with lumbar today. Okay, so the cervical spine supports the head, provides attachments for these muscles and the upper extremity. Obviously, it protects the spinal cord. And there's a large range of motion that's necessary for balancing and supporting the head. So some unique vertebrae that are found here at the level of the cervical spine is the atlas and the axis. So C1 for cervical 1 supports the skull. It's got a concave superior facet that articulates with the occipital condyles of the base of the skull. So this is what the head sits on, essentially. This is like the platform of the stand that the head rests on. The axis, or C2, has this very easily identifiable structure known as the dens, or the odontoid process. And that's this sort of thumb-looking structure that sticks up. And this is an attachment site for ligaments. And we'll talk about those ligaments here in a second. These ligaments that kind of hold this in place allow the transverse movement or shaking of the plane no in this direction. In contrast, C1, or the atlas, is responsible for the yes motion. But you know that the way that they interface, right? We don't just move in two directions. I mean, we can go all the way around. So a lot of ability for us to check out our surroundings, see what's going on, whether we're being a predator or whether we're actually trying to not become prey. So here's how they fit together. You can kind of appreciate the dens that protrudes just above C1, and we've got this transverse ligament that wraps it. And we also see that we've got two ligaments, slightly different slice, but you can appreciate the dens and the transverse ligament here, and then alar ligaments that actually interface on the right and the left side, giving us three different ligaments that support and hold in place C2 to C1. So, shouldn't be a surprise, but one of the number one injuries in the cervical region is of these ligaments. And it's exaggerated when a patient, is, turning to look behind them, and then they're hit from behind, and they have whiplash. So if the neck is slightly rotated and there's an impact, you've got an injury under a flexion-extension situation. And in particular, the alar ligament is susceptible to injury or tearing or rupturing. So the alar ligament is the most commonly injured structure in whiplash patients. So about 66%, 67% of the time, the alar ligament is actually what's impacted. Secondarily, you could have partial dislocation. That's what the word subluxation means. Partial dislocation of these joint spaces, the atlantoaxial joint, which would actually impact not just the alar ligaments, but also that transverse ligament. So the transverse ligament is less likely to become injured, but in extreme cases, it also too can become injured in a rear end motor car vehicle accident, okay? Something that many of you in your future lines of work will probably be working with. The thoracic spine. So this is the transition between the neck, or the cervical region, and the lumbar regions. And it is an integral part of the thoracic cage. And the thoracic cage is important because it protects many of our vital internal organs. So similar picture as before, highlighting this normal wedge-shaped, meaning it's thicker on the posterior aspect, thinner on the anterior aspect. And this is a normal thoracic kyphotic angle. A lot of weird words here, right? Thoracic kyphosis. So normal, this is that original shape from embryonic development. This is what we would expect to see on X-ray or under radiographic imaging. But as we get older, and I actually am going to predict, you all can stay in communication, because by the time that I'm really old, you all will be practicing in your profession. You may, in fact, be taking care of me, right? If we're in the same town. I might pull up your grade to see if I'm going to come see you, but I'm kidding. What do we do these days more and more and more of? Right? But as we get older, and you can see this in patients, as we get older, we slouch, right? It's more painful to maintain these postural muscles. It takes a lot of energy. It hurts. And so that's why, we're always talking about posture, but this to me is probably going to be a major epidemic of your future patient population that you're going to be treating, is severe thoracic kyphosis. Now, it says secondary to osteoporosis. Well, an osteoporotic state exaggerates this severe kyphotic angle. Severe kyphotic angle, or slouching disease, whatever you want to call it, as we get older becomes more and more prevalent. And obviously in our elderly female population, if there's an underlying osteoporotic signal, it could become more exaggerated. Right? The other thing that we know that happens as we age, you've heard this, right? We shrink. Because in between these vertebral bodies, what do we have? Cartilaginous discs that are spacers. The cartilage wears out over time, and now you have shorter distances between vertebrae. It's not uncommon over the entire vertebral column for you to lose 2 to 3 inches in height between a patient in their 20s and a patient in their 70s. So now you have compression of the vertebral column, you have osteoporosis, you have poor posture, and this puts excessive pressure on the vertebral column, specifically in the thoracic region. Okay, for this next slide, I want to actually show this radiograph. And these are compression fractures of the thoracic region that typically occur in this anterior portion of the vertebral body due to an increase in severe kyphotic angle and underlying osteoporosis. As the bone density deteriorates or becomes less and less, and now the force vectors on the bone are pathological, we start seeing these compression fractures. Okay? All the more reason to sit up straight, walk straight, text like this, right? Or audio text. All right, lumbar spine. We're working our way down. Lumbar spine. Repetitively sustains enormous loads. In fact, the vertebral bodies are much, much larger. Like as you move superior or inferior of the vertebral column, the vertebral body of the cervical vertebrae is very small and almost dainty and delicate. Thicker as you get to the thoracic region, and it's most robust in the lumbar region. One of the easiest ways to identify different vertebral bones sitting on the bench top and lap. Look at the size of the body. But it also really needs to have mobility so that you can bend down and tie your shoes. You can pick up your pencil, right? You can wash your feet. For elderly patients, foot care is hard. It's really hard. Now you have diabetic patients, Maybe they're slightly overweight. They have diabetic neuropathy, meaning they can't really feel. They have small little cuts and abrasions on the bottom of their feet, and they can't reach them to clean, to take care of them, right? So it's a really important region of the body. Not that it's more important than the thoracic or the cervical region, but when you consider the aggressive nature of daily activity and the amount of pressure and stress and load that's placed on the lumbar spine, it doesn't surprise us, shouldn't surprise us, that it's a common location for injury. We're not going to talk about all of them in this class. I'm trying to give you some clinical examples just to kind of fill in the story so that you guys can appreciate how it's designed, how it functions, and then some things here of when it goes awry, right? Because I think now you start in this class, the beautiful thing about this class is you start getting these little clinical vignettes of, oh, this is why we learned all that other stuff, so that we could actually learn this stuff now that I want. This is what I really want to do, right? I want to do herniated disc surgery, right? So what is this? Well, you can see here that we've got healthy discs, spacing in between vertebral bones. And you've got one that's labeled here as a herniated disc, and it's putting pressure on one of the nerve roots that's coming out of the spinal cord. So I'm right here. So this compressed nerve root coming out of the spinal cord is because this disc is traumatized. And so the idea, this is called a herniated or a slip disc. It could be a ruptured disc if it actually completely comes out of this capsule. But these discs get damaged under injury from normal wear and tear, or disease that takes place, or excessive force production that takes place. Like in our elderly population, a lot of our occupational therapy, our home physical therapy will tell our older patients, if you need to pick something up, don't twist and bend, right? Because this twisting motion and this bending motion, like, wouldn't that be hilarious if I just like threw my back out demonstrating? Funny, haha, right? So we tell our patients, turn and bend down at the knees, right? So you don't want to have these twisting and bending motions, especially in our older population. Now, as we age, we tend to put on weight too, right? So now it's exaggerated because we're carrying excess weight, more mass, and we're doing these exaggerated activities, and we're not thinking about it carefully, and that's where these traumatic events take place. Question? I don't know if you already talked about this, but what are the discs made of? What are the discs? We haven't talked about what the discs are made of. I'm going to get there here in a second. There's two portions. There's like a gel in the middle, and then there's like a capsule on the outside. So give me a couple slides, and we'll get there. So the disc itself, the intervertebral disc actually lies in front of the spinal nerve, so they're very susceptible for pressure. 80% of this load through the level actually is going through the disc. Now, why not 100%? Why is it not 100%? Vertebral body, disc in between. Why is it only 80% going this way? Where's the other 20% transmit? Down the transverse processes, other connecting points that move to the inferior vertebrae. So 80% comes here, but you can see how these touch here. So some of this force actually transmits around here. It's not 100%. If it's 100%, we probably have more disc injury than we do today. Okay, so these images, two different types of images, CT scan on the left, an MR scan on the right. And I think it's a little easier to see the disc bulge under CT. So you can hopefully appreciate, so here's our bony structure. Here's our disc in white. And right here, where this little triangle piece pokes out, this is the bulging disc under CT. You capture that? So that's the culprit. So what do we do? Well, PT, correct the behavior. You may have PT where you alleviate pressure on the disc. So you can actually do traction with the patient, where you kind of put them in bracing and you actually can pull gently under heat. And slowly over time, under sustained traction, you can manipulate pressure off of the disc. So the patient lays down. That's why I'm going like this, not like this. Usually the patient lays down, right? You'll heat up the back. You'll fix the hips. You'll pull on the chest and you'll move the head this direction and keep the hips stationary. You try to alleviate pressure on the disc. Okay? It can reabsorb. The bulging disc can reabsorb as long as it's not damaged. So in this picture, you've got two structures. You've got the gel in the middle, to your question, the gelatinous material in the middle, and then you have an annulus that surrounds the outer sort of ring. And it's that annulus that tears, and the annulus architecture is reinforced by collagen fibers. And these collagen fibers are in a hatched-like architecture. So you got fibers going this way, and you got fibers going this way. Now, back to our tissues lecture. If you have fibers in one direction only, is it stronger or weaker than fibers in multiple directions? One direction only is stronger or weaker? Weaker. So when the fibers, the collagen fibers of the annulus are oriented like this, just like I'm standing, nice and strong. When I twist, guess what they do? I twist to the side, they line up. So I twist to the side and then I bend over. That's when it tears. Make sense? So it's all about the microarchitecture. So this annulus is made up of reinforced collagen fibers for tensile strength. They're in a hatched-like architecture. It's not irregular, dense connective tissue where it's all over. It's just two directions. That's it. Why? I don't know. That's above my pay grade, why it was made that way. Okay? But it's like this. So in this position, I bend over in this position, nice and strong. I twist and they align, and I bend over in this direction. That's when it's weakest. Make sense? All right, so what we do here is surgery to actually remove this bulging disc. If PT doesn't work, if you unload it, if it doesn't reabsorb, or if the annulus is completely torn, you might have to come in and do disc surgery where you'll cut out the bulging portion, alleviate the pressure on the nerve root to eliminate the pain. It's not a long procedure. It's actually pretty straightforward. Maybe an hour actual cut down time. There's going to be prep time and there will be post-operative time. So it's probably like a 3 to 4 hour surgery. But the time that the neurosurgeon's actually working on the patient from first incision to close is probably an hour, plus or minus. Questions? Okay, a disease of the lower back or the vertebrae as we age is known as spondylolisthesis. Spondylolisthesis. So this is the anterior slide of a vertebrae. So I'm standing in this direction. The vertebrae on top slides forward, and the vertebrae in the inferior portion either stays stationary or slides back. So this is spondylolisthesis. Forward displacement or the anterior displacement of the vertebrae that's superior. And it's very common in L5. It's most common L3 to S1, right? Often happens after a break. So here's an image of a patient. And I want you to kind of orient yourself. So where we are right now, this patient was born in 46, right? So 8 years of age. And we've got this anterior slide of L5 over S1. You see this displacement as it's sliding this direction. Spondylolisthesis. All right, questions over material from today. All right, we got a little bit more time, but this is a nice place to pause for today. We'll finish out the rest of the lecture on Monday. You can see that there's not a lot more material for us to cover. We are going to cover reflexes. We'll cover a little bit of how the architecture of the spinal cord is made up. We'll talk formally about the decussate on Monday, and just kind of wrap things up before the exam. Right? Really only about 10 to 12 slides of material on Monday. All right, have a great weekend. Please start your studying over the weekend, maybe as if the exam is on Monday. Pretend like the exam's Monday. Come to the review session on Sunday.